Welcome to today's webinar. My name is Chris McCullough. I am the EP Marketing Manager for Cardiva Medical, now part of Haemonetics. I will explain the format of today's call. All Zoom participants will be on mute during the presentation portion of the Zoom meeting. During the presentation, please send your questions and comments using the chat function in Zoom to Roger Owens, who will gather questions and ask our speaker at the end of his presentation. You will see instructions for sending a message through chat at the bottom of each slide. Now I will hand the microphone over to Roger Owens, Vice President of Sales, Marketing, and Business Operations.
Chris, thank you, and thanks to everyone who's joining us for the East Coast. I know it's a little bit late on the East Coast and Central, and then on the West Coast. Thanks for everyone joining us at the end of your day. As Chris shared, my name is Roger Owens. I'm Vice President of Sales, Marketing, and Business Operations for Cardiva Medical, now as of March, part of Haemonetics. So we're pleased to host today's webinar. And during today's discussion, I think you'll see a lot of compelling clinical data we'd like to share with you. And Dr. D'Souza will be sharing about an exciting technology that we've been working on and launching, which has enabled a change in workflow called the VASCADE MVP. And during his presentation, you'll have an opportunity to see some case videos, and then hear how a major center implemented a same-day discharge program. And so we're really excited to host you all tonight, and we're also very privileged to have such an outstanding speaker today with us that I've had a chance to personally meet, which has been great to start seeing people again. So for those of you who don't know Dr. D'Souza, Dr. Benjamin D'Souza is currently an electrophysiologist and assistant professor of clinical medicine at Penn Presby Medical Center. He completed his BSBA at Villanova, earned his medical degree from Jefferson Medical College at Thomas Jefferson, and then finished his residency, cardiology and fellowship, and EP fellowship at the Hospital University of Pennsylvania, or HUB, more affectionately known. So you can clearly understand from that background that Dr. D'Souza is rightfully so and well-earned a passionate and loyal fan of the Philadelphia Eagles, which determines or absolutely shows a lot of resiliency and a lot of pride. So without further ado, I would like to introduce you to Dr. Benjamin D'Souza. Thanks.
Thank you, Roger. Thank you, everybody. Thank you, everybody from Cardiva and all that are joining me. I'm sorry that we're not meeting in person like we normally would do, and be having a glass of wine and waiting for you to put your entree orders in before we actually get to do this talk. But as we all know, we're still dealing with the pandemic and hopefully moving in the right direction. But until then, we have to do everything virtually, but still try to educate each other and learn from each other and, do the best that we can for our patients. So, as Roger had mentioned, I work at Penn Presbyterian Medical Center at the University of Pennsylvania here in Philadelphia. We're a large tertiary care center, trauma center for Philadelphia, and we do a high volume of procedures, including cardiac ablations for arrhythmias, including electrophysiology. And we're going to be talking about sort of the data behind the VASCADE system and how I use it. The first half of the talk will be sort of structured in discussing the data behind it and the use of it for groin closure, venous stasis. And the second half is going to be my experience with it and sort of how I've used it to take care of my patients. So we're going to start with some clinical data. So, when I was first approached about the VASCADE system and its use for, venous closure, I was skeptical, like any of us. I think all of us within any sort of interventional procedural specialty, we get approached all the time about devices and about new technology and about things. And, we always have to put our guard up. And like I said, I was skeptical at first, but now I'm, very much an adopter of the technology, and I'll explain why. So this was a clinical trial. And so for the first question I asked, like with any device or any thing that we use, is what's the data behind it? And so this was, a clinical trial that Andrea Natali and others put together, looking at essentially what's the benefits of using the system? And so, the primary endpoint was time to ambulation, getting up out of bed rest and complications. And then there were secondary endpoints, including, time to hemostasis, procedural time, ability to get out of the hospital, actually being discharged from the hospital, the success of the device, and any minor complications. And additional data that, I think is going to grow to be more and more important over time is patient satisfaction and how the patients felt about it, and how they did, and whether they needed additional medications to treat, either groin or back related pain. So not surprisingly, the use of a device to be able to close the venous puncture site and get patients out of bed worked a lot better than just manually holding pressure. And so, in general, for our patients, 4 to 6 hours is the standard and the norm. But with the use of Vascade MVP, the reduction comes to about 2 hours. And so we routinely set our patients up in 2 hours as opposed to 4 to 6. And that was clearly statistically significant in terms of difference, which, is obvious. We're going to talk about the specifics of what the actual device is and what it actually does. And also, not surprisingly, patients were happy. I mean, my number one complaint that I get from patients immediately post-procedure and in follow-up is, I had to lay flat. I was on a cold table all day and I'm on this uncomfortable bed. I had pain. And so I think that, most of the time we tell them just to deal with it, or we try to oversedate them to deal with it. But, I've had many patients be particularly thrilled that they can sit up in 2 hours. Unfortunately, obesity is another epidemic that we're dealing with, and the low back pain and issues related continue to be an issue. And getting patients off of bed rest as quickly as possible is important for their patient satisfaction. So the clinical trials and sort of the data that goes behind this is not sort of just one study, and this is sort of summarizing all of them. We had just mentioned the Ambulate pivotal trial, which was, again, the randomized control trial I just mentioned that led to FDA approval of the device, which was published in JACC EP, and again was Andrea's study in 2019. We'll talk a little bit more about a study that is also of interest from an economic standpoint. So unfortunately, in the climate that we live in, cost per case and how much things cost has become even worse, with hospitals losing money and sort of people tightening the reins of what we can and can't do in the hospital. And so the second question I had when I heard about this device first was, does it work and what's the data behind it? And second was, is this going to cost a lot more? Because if it is, then we're going to have trouble getting it approved, and the hospital administration is not going to like it. But I'll show you why this actually is the opposite. And then data that just continued to be gathered as we continued to take care of patients with this, looking at continued access, protocol, as well as the same-day discharge registry. And we're going to spend some time talking about how I utilize the technology for same-day discharge and getting my patients out of the hospital who've had either, an ablation of regardless the type. So the next day same-day discharge registry, and again, we're going to spend a lot of time talking about this. This is a pretty hot topic within EP right now for multiple reasons, which obviously we'll talk about moving forward. Certainly, as we had said, the main reason that we're not all sitting together in a room and talking about this is because of COVID-19, and it's part of the many reasons that we need to get patients out of the hospital. But this was an issue before COVID, and it'll continue to be an issue after. And so this was basically a registry looking at that. So fairly large one that looked at multiple patients, multiple centers, investigators sort of across the country. And the data is reflective of what my data is too, is that 90% of patients were successfully discharged the same day. And they did not require some sort of intervention after, meaning have to come back to the hospital for groin related issues. And there were no major complications from the device itself or related. So the data is out there. It's been shown in prospective and in retrospective data that it works. The basics of the device, I'll show you how it works in a little bit on a patient of mine, actually. And essentially, it can close a 12 French inner diameter sheath, which is most of the sheaths that we use for any type of ablation, including cryoablation and left atrial appendage closure with a Watchman device. The Watchman sheath, so the double curve sheath, is what I use for most of my procedures, like 99% of them. And that's a 12 French inner, and that can certainly be closed with this device very well. I I did 5 Watchmans yesterday. I closed all of them with this, and they did great. It's a multi-access site bilateral usage device, which is the only one that can use it. And the device itself is actually collagen. So essentially what it does is, what I tell patients is, it plugs the hole and leaves bioabsorbable collagen. So as opposed to other devices that are sutures or clamps or something that leaves behind in the patient, this does not. It's extremely easy to use, which I'll show you in just a little bit. And so this is the only device, as I mentioned, that is allowed to use for several access sites. So for AFib ablations and really everything that we do in the EP lab, we generally have multiple sheaths on both sides. You know, when I was a fellow, we were putting 3 sheaths in on the left and 2 on the right for an AFib ablation. I do less now, but still, at least 3 or 4 on almost every procedure. And as I had mentioned, the Ambulate pivotal trial showed that you can close multiple venotomy sites. And even if there are 2 sheaths there, because you don't have a stitch or anything, that you're not really going to cause any issues with the groin itself. And you can use it, and it's the only one that's FDA approved to be used in patients who have multiple access. So the device itself, again, as I had mentioned, there's not really any permanent leftover parts. The compression of a mechanical disc while you're deploying the collagen, and then the physical compression that occurs with the collagen itself. That collagen expands up to 13 times, so it really does expand in the site itself. Because I was confused when I first looked at the device how small it was, and if you're trying to close, the hole you just made with the Watchman sheath, you're like, this isn't going to work, but it actually works beautifully. As I mentioned, no sutures, and it's extremely easy to use. And so you can re-access the site about a month after. If you have to access before, you can puncture either above or below the site, and it's not an issue. Not that I've had to do that. And as we mentioned, the benefits are you can get patients up out of bed quicker and get them out of the hospital quicker. And there are multiple reasons that that's important, which we'll talk about. So this is what it actually looks like. And this is a patient that I did a combined Watchman and AFib ablation, did the whole procedure with just intracardiac echo and not TEE. And so you can see that big sheath that I have on the right groin. So my recommendation is, if you're going to be doing this with large sheaths, larger than an 8 or an 8.5 French steerable sheath, is you have to downsize the sheath to a short sheath. So you can see me taking an 11 French sheath there, downsizing. And so so I basically take that out and let it sit. And so my impression when I first did this was, this is going to bleed like stink around the sheath. This isn't going to work. But it doesn't. Actually, the vein starts to collapse around it. And then my recommendation is to do this properly. Let it sit for a couple of minutes if you can. And so you can see that I'm actually closing the other groin. So I use intracardiac echo. So you can see me taking out the 9 French sheath there. So what I had already did was basically put the device in, inflate the disc. We drop the key into the lock, remove the lock, and now the collagen is indwelling. So we let that sit for 30 seconds. If I wanted to go quicker, I could basically clamp this and move on to the other groin. In this case, I kind of want to let time pass so that bigger venotomy is starting to spasm down around the 11 French sheath. So let it sit, do its thing. And then after that, what I'll do is essentially strip the collagen and allow it to dwell in the venotomy site itself. And then you can see me doing that there. And then I have my scrub tech or nurse or anybody with gloves on just come and hold pressure. So essentially hold pressure for 2 minutes. We do still give Protamine for these cases. You don't have to. It just may mean that you need to have a longer hold. So while my scrub tech is holding for 2 minutes on that groin, then I'll go ahead and close this groin. Same concept. It does not increase case times. In fact, now, as soon as we wake the patient up from anesthesia, we can get them right off the table. We don't have to wait for an ACT to come back. That's less than 200 to pull the sheaths. Depending on where you pull these sheaths, if it's happening in the lab itself or even in a holding area, you don't have to transport the patient with sheaths in. Or in our case, we actually do pull the sheaths in the lab for a couple of reasons. So, depending on how long it takes for that ACT to come down, it is certainly improved by being able to do this. And I'll mention a couple of things that can help workflows speed up even more so. And so that's pretty much it. It's really that easy to be able to deploy the device. It is not complicated. I've used other closure devices that require you to do stitching and stuff like that, and it does not require that. And so many folks who will close the left atrial appendage sheath, like a Watchman, they'll put a stitch in. And, you know, I've had some pretty uncomfortable patients who've had stitches in, to be honest. It works, but you have to remove it. So if you're going to send your patient home the same day, it's kind of hard to do that. And so, in addition, my nurse practitioners love me when I don't have to put the stitches in because they don't have to take them out. And so, there's multiple people that will be happy if you use this device, and I'll explain all of those people, including your patients. So I'm going to sort of transition now to talk more about our experience at Presby and how I've sort of adopted this technology. And as I'd mentioned earlier, was skeptical. When I was approached about it initially from a rep that I've worked with for years, who had transitioned to Cardiva from a previous company, I told her, I said, I don't really need this. We have very low complication rate at Presby for our groin-related access. We set our patients up when we can, and we send them home the next day. But looking back on it, thinking of what we previously did, I think is fairly archaic. And so, manual compression, essentially what we would do, and this is what many people do, we basically would take a giant ball of tape. We just waste a lot of tape, and then we would tape it down to the patient as much as we could, and then take it off the next day. And I have found that when I am the person who's rounding on the weekends and there's not a nurse practitioner to remove that tape, my patients hate me. And so, you're ripping tape off, you're ripping skin off. And I don't really know that it works, but we were doing it and we're like, well, it's easy enough to do. As I'd mentioned, per close, I did use as a fellow largely for arterial related access, but we use multiple access sites. It's not necessarily indicated for that. I've also seen some pretty bad arterial complications from this device, and so I didn't adopt it. Figure of 8 I really liked and was using for Watchmans and for other bigger sheaths like a micro, which I still do. But again, requires you to remove it, and you have to be careful that when you're using that big needle that you don't hit the artery and you don't tie down something. I've had some patients have some pretty uncomfortable feelings with that overnight, and you have to take it out. And then now, of course, I use Fastgate. So, as I had mentioned, we're all living in a post-COVID world. It's hard to believe it's been, over a year since all of this, but we had a bed situation at Presby that predated this. And this is like many hospitals across the country, and certainly here in Philadelphia, that it was always difficult for us to get beds. It's a busy hospital. We have lots of patients and lots of people that are coming in for procedures and for other reasons. And so elective procedures prior to COVID was the trouble. Post-COVID was non-existent. We shut down the hospital like many other hospitals to free up those potential beds for months. It was a very, very difficult time. I was sitting down here in my basement where I'm now, having telemedicine visits with patients who are having AFib with RPR and are having heart failure, and just telling them we can't do anything. And so I really hope that I never have to go through that experience again, because it's very humbling and difficult. But now we're able to get patients in the hospital. When we started to open up again, and I think most people experience this, is that they didn't want to come into the hospital if they didn't have to. And so I take care of a lot of patients that are sort of in the suburbs of New Jersey or other areas, and they were terrified about coming into Philadelphia. They thought that Philadelphia was going to be the next hotspot. They were going to get COVID-19. Of course, this is prior to vaccinations and other things that we were doing when the numbers were spiking every single day. And so the concept of same-day discharge was always there, and always something that I had kicked around, but never really adopted because I didn't have any incentive to. And one of the minor benefits of COVID-19 was that it really did push us to start to look at things and say, what, we should reevaluate how we do things. And so that's what I did with this. And essentially it said, if I can get you out of the hospital sooner, get you up out of bed and home that day, what would that do in terms of difference? What would that change? And so For patients, it was a huge difference. So talking to patients either virtually or now in person and discussing with them that, listen, it's very much an option that you can go home that day. Listen, I think it's going to be safe if you stay in the hospital. It's perfectly reasonable. People are vaccinated. You're not going to be around patients with COVID-19. But if you want to go home, I'm comfortable with sending you home, is really empowering to patients. And they really do like that. And beds in the hospital, as I mentioned, is a big deal, and it continues to be a big deal. We are constantly trying to find a bed for a patient after a procedure, and that's very similar to other places. And so it really helped to offset some of the load of patients that were coming into the hospital that needed to come in for either COVID-19 or the other issues that we were ignoring because of COVID-19. And so, like many other places, the structure of where patients go and when they can go home is complicated. I sort of equate it to, Cinderella, that after 6 p.m. in our hospital, the outpatient area turns into a pumpkin. There's no way that we can send patients home from there because people have to go home and it's not staffed for overnight. And when a patient goes to an inpatient bed, the nurses there are not planning to send that patient home. The moonlighters have no intention of sending the patient home, and they're going to stay. And almost routinely, if I send a patient to the inpatient floor and say, you can go home by 8 o'clock and I'm home, they're there the next day. And that's very similar to many other institutions. And so the ability to cut that time from 4 to 6 hours to 2 made a big difference. And that 2 hours means that I can finish a procedure at 4, which is pretty routine for my second or third case, and still get the patient home that day. And so we call it the bowling alley. It's our outpatient area because it's really long, like a bowling alley. And so I can get patients home that day regardless. We used to schedule the patients that could go home that day first. But then with the bed crunch that we've had, we actually were doing the patients who needed a bed first so that we could get in the queue for that bed earlier. It's sort of the opposite of what you would think. And then we were doing the patients who were going to be able to go home later in the day, but then they were going home at night. It really wasn't ideal. And this allows you just much more flexibility. In terms of administrative support, I had lots of administrative support for this because I was basically freeing up beds in the hospital. And so we'll show you data that essentially shows that this lowers overall healthcare costs. It is a quality improvement initiative that your administration will support, and certainly was supported for me at Penn. And so, time is money, right? And so that workflow in our lab was important, but we're already extremely efficient at Presby. Our staff and everybody works really hard for us to get the patients and to get them out quickly. And so it's not really feasible to just build more, honestly, even though we would love it. And that inefficiency and that inability to get patients out of beds and out of areas can foster, dissatisfaction for us. I many a time had our nurses where we finish our procedures at 4 or 5 o'clock, and I go home and they still have to stay there for hours with the patient until we can get a bed for them. And it's really not fair. And it's not what they're signed up for. And it leads to sort of a spiral. And this has helped sort of improve that. And the getting patients out, as I mentioned, was a big deal because it freed up those beds for the other patients who were going to stay. It freed up those beds for patients who needed to be transferred into our hospital that couldn't. And it allowed sort of the patients to go home, and that flexibility to really do whatever you needed to do in terms of the schedule without that concern that they weren't going to have anywhere to go. So the staff was happier. The outpatient areas were happier because we were getting the patients out. The schedule was easier to do. And honestly, most important is the patients were happier. And really, that's sort of why we do all of this stuff. And so I can tell you that, patient satisfaction and the follow-up with them at the 1 month visit, post when I'm asking them about how their groins and how they're doing, it's big. And obviously it's not just groin closure, but that is a big part of it. And so I really did change completely how I took care of patients when we did this. And so, as I had mentioned earlier, the main concern, obviously patients, when they meet with you and they talk about having an AFib ablation, their concern is about the procedure itself, of course. And unfortunately, through all of those months, last year through COVID, many patients delayed their procedure significantly. Patients who were paroxysmal became persistent became long persistent. Their atrium dilated. They had heart failure. They came in worse because they were scared. And so this allowed me to essentially get them in and get them out and still be able to provide that care for them. And, a big part of this is education too. So education to our referring physicians when they're talking to the patients about seeing me, that it's not a 10-hour procedure, that you're going to be in the hospital for days, and, complication rates are high. It's a procedure that you can do relatively quickly and get them out of the hospital. And educating the patient community, the doctors, everybody about that this is a potential option for them. And I do believe strongly that this is going to be the future of how we take care of patients, in particular for AFib ablations, which is, another epidemic in terms of patients who have AFib who need an ablation. So not everybody can go home who has AFib and who receives an ablation. And these are just some of them. When I adopted this initially, it was patients who had paroxysmal AFib, which is normally, a shorter procedure. It's more straightforward, healthier patients. Normal ejection fractions, not heart failure. Did okay with anesthesia, no reactions or issues related. And I think that heart failure is a big part of it. I think if you get left atrial pressure of 30, you probably shouldn't send that patient home. They probably need to stay for some diuresis. Foley catheters, I stopped doing. A friend of mine published a study that clearly showed that Foley catheters associated with complications, which is obvious, but important. And I think that with getting patients up out of bed, even if I need to give them some Lasix before they leave, I can do that. Sit them up in 2 hours, get them squirt of IV Lasix, and still get them out the door. Give them more oral Lasix when they go home, and they do just fine. Obviously, pericardial effusions is, a concern. I use intracardiac echo, and I'm very careful to make sure there's nothing that's changed during the procedure, at the end of the procedure. If there's anything that was squirrely about the transeptal or about the ablation or about CS catheter access or anything, I keep them just to make sure. And then, of course, groin-related complications, if you're struggling and if there's issues, Vascade is not going to prevent that. That collagen plug is not going to prevent a pseudoaneurysm or a fistula or something else that you did from access, but it can certainly help in terms of getting patients up. And then obviously there's some social things that come into this. I have patients that live alone, and they are 90 to 100 miles from the hospital where they had their procedure. They're terrified of going home because if they have an issue, they have to go to their local hospital, and they don't want to do that. They want to come to Penn. And if they don't have someone to care for them and watch for them, then that's a particular, issue as well. And so I give them the option. I'm not forcing anybody out of the hospital. I tell them that, but I say, listen, if I'm comfortable with you going home and you're comfortable with it, then together we can get you home, and we're going to keep an eye on you. The other thing that we do is that we have our nurses and nurse practitioners call the patients the next day. We have been doing that for same-day discharges for devices, and we do the same thing for ablations as well. And so, the goal when we initially adopted this was sort of a pilot program in which we would send 20% of the patients home who had closure or not, just in general, but in particular ones that were second cases or ones that needed to be closed. And this is my data, and essentially sent home 90+% of patients for same-day discharges for my AFibs over the course of last year, which has been wonderful for multiple reasons, as I sort of alluded to earlier. And so now we can sit the patients up and get them out of the hospital, which is, a big part of why I adopted this, in addition to all the other stuff we had talked about. And so financially, does this benefit the hospital? I mean, if you take a step back and think about it, of course it should, right? You're freeing up beds and all of those things. But, what does it look like in terms of a study? So this was a study that essentially looked at 2 hospitals in New Jersey and in Austin, Texas, and looked at the adoption of Vascade MVP in terms of cost savings. So this is a big deal for everyone, as we had talked about earlier. I personally care more about taking care of the patients than cost, but someone has to think about this stuff, and it is important. But the way that it saved money is essentially lab time, resource utilization, length of stay, and clinical events or complications related to it. And in general, saved close to $2,000 per patient versus manual compression. The thing that is not characterized in the study, which I think is extremely important, is that bed that was taken up by a patient. What does that revenue difference make for the hospital? And it's significant. It's not able to be characterized easily, but I do believe that it to be important, not just for clinical reasons, but for financial and economic reasons as well. So we looked at our own data. And so it's essentially looking at a same-day discharge program that includes the cost of the device, right? So you're using a device that increases your incremental cost. And when folks look at this, they say, well, you're using this device that costs X amount. You increase your cost per case this much, but you're really, missing the forest full of trees when you look at it that way. And if you look at the data in about 500 patients, if you did this with a same-day discharge program, you'll save the hospital almost $900,000. So that's important. I'm not necessarily getting any of that money, but it is important for patients and for your hospital and the economics of it. So it's easy to use. It's clinically important. It can get patients out of the hospital, and it saves the hospital money. So it's sort of a no-brainer from many of those standpoints. And so I'll finish a little bit early so that we can spend some time talking, but I want to summarize some of the things that we had talked about, and that the AFib ablation patients, they really do appreciate getting them up and getting them out of the hospital and getting them home sooner. And I can tell you that, the patients that I see in follow-up, it matters. Now, currently reimbursement for procedures is not necessarily tied to quality, but we all think it's coming. And we all believe that patient satisfaction scores are important, whether it be for hospital rankings or for, things that may be tied to physician reimbursement in the future, to be honest. My patients love it. I always ask, the first question I ask, how are the groins where I place the catheter? And they're like, oh, that was great. And so I really do enjoy hearing that, because I hate hearing that was torture. Like, I was black and blue and in pain, and it was miserable laying on the table. And so, I used to have to joke with my patients, I don't want to see you for at least a month from the procedure because you hate me for a month. And so I don't have to make that joke anymore, which is a nice thing. The lab and staff workflow it's significantly improved. Everyone, like as I had mentioned, everyone, nurse practitioners, the nurses in the lab, the nurses in outpatient, everyone's happy in addition to the patients when I do this. And I'd mentioned sent home 95+% of my patients in the last year. And I do a lot of AFib ablation. I do probably, over 200 to 300 a year. The learning curve is easy, honestly. And so I think for people who say, well, it adds time for me to have to do it, I don't really feel like doing it, I'm not the one holding the groins, I'm the doc, I've already moved on. Well, honestly, what we did at Presby, we taught our staff how to do this. And so this is yet another added benefit. And so I think in general, when you engage your lab staff and your techs to be able to work with you, they care more about the procedures. They're paying more attention. They have skin in the game. And so they enjoy being able to do things. And many people in EP like to do stuff. We like to do procedures, and the nurses are the same. And so if they're really just sitting there and documenting and giving meds and not necessarily getting to be involved in any procedural aspects, you are sort of shortchanging them. And for me, this is great, because I have our nurses and techs that we're all, we're training now and already have trained some. And I just basically downsize whatever big sheaths need to be downsized to short sheaths. And I'd say, our scrub tech, her name's Annetta. I'm like, Annetta, it's all you. And then I walk out, and then I basically sit in the control room while she's doing it. And I write my note, and I text the referring, and I get ready to talk to the patient's family members. I get ready to answer all the emails and texts and all the other crap that we have to deal with. And then they wake the patient up. So I'm more productive. The lab is more productive, and the nurses and the staff are happier. So as I had mentioned, it's really a win for everybody. And I really have gone from someone who was pretty skeptical about using this device at all to being very much an adopter of it for all of the reasons I mentioned. And so, I'm hopeful that I'd recommend you try it and really talk to your patients about it, and consider using it for something that's a quality improvement initiative at your hospital and for your patients. And so just some important safety information. I'm going to skip past this because I have to show this slide. And then, disclosures. I'm an equal opportunity employer. And, the benefit of getting your patients out earlier is that you get to go home too. You get to spend time with your family. This was a couple of weeks ago, my two boys, Rivers and Desmond, who, I took to Disney World, which is a little weird with the mask and stuff like that. But the point is, I love my family, and they do like to see me once in a while. And the chance for me to be able to go home and see them is important. It's important for all of us. And I think that anything you can do to get out of the hospital earlier and get home earlier is a benefit to not just your patients, but to you and your sanity as well. So I will leave it there and hopefully have plenty of time for questions, and I'm happy to answer anything at all. Thank you, guys.
Thanks, Dr. D'Souza. I I should have shared this when I was doing the introductions, that we may actually see your two children walk in the background. So I appreciate you sharing that. So, Dr. D'Souza, thank you for that. And I just appreciate the genuine authenticity of just sharing your message and sharing kind of your path. I got a couple of different questions, and I've been kind of scribbling furiously in here.
Sure.
One of
Go
the
ahead.
questions that came in, I think you just mentioned it at the very end. It said, do you plan to hand off closure to the techs in your lab? And I think you just mentioned a person named Netta who is
Yeah,
in
so
the lab.
she's one of our scrub techs. She's wonderful. And, when we hired her, she particularly said, Ben, I really want to do more. Like, I don't necessarily just want to prep the patient and stand there while you do everything and I just hand you stuff. And she wanted to learn how to get groin access. She wants to learn how to, close a pocket. She wants to learn how to use the Pruka and the Bloom. This was a part of it. And honestly, as an adoption of a technology, it's about as easy as it can get to teach someone how to do it. And what I told her when we first started, I said, listen, if you mess it up, we're just going to hold pressure on the groin anyway. That's what we've been doing for years prior. So don't worry. But she did great. Like, honestly, now she does it better than I do. And so it's quick, and it really does. It frees me up. It really allows me to do all those things that I mentioned that, my phone's blowing up and I got to do all these other things. And I can start doing them, while we're waking the patient up. And we time it properly so that right as the groin closure is done, the patient wakes up from anesthesia. Again, I still use general anesthesia for my AFib ablations and will continue to. So, that has, like I said, they have skin in the game now. It makes the procedure more enjoyable. In fact, I've had a lot of our nurses are like, I want to learn how to do this. That's something I really want to. And they're like lining up. They want to be the one who's the best at doing this. And so it's really nice to see. And I think it's been helpful for all of us.
And Dr. D'Souza, I was kind of sifting through a couple comments, like brilliant video, which was not developed by us. That was you for the videos. So a couple comments on that. A few other comments. You had shared a little bit about the complication that you've had, zero major complications kind of in the year that you've been doing, and you do a lot of AFibs. I think this one's related to that. The question was, and I think you answered this earlier, but for access, are you using micropuncture or are you using ultrasound for access?
Yeah, I use ultrasound for access. I started, during fellowship, went from, we didn't have ultrasound access readily available, nor thought that it was quote unquote necessary, to using it. And thankfully, between my first and second year VP fellowship, used it. And I'm honestly completely reliant and dependent on it to the point where I refuse to get access without ultrasound.
Okay.
I don't use micropuncture for groin access, but it's also a good idea. And our vascular guys do use that for arterial access and for other things. But I think having a ultrasound is crucial. I honestly have not done a single in the last 500 cases without ultrasound, and I refuse to now. So, like I said, I'm dependent on the technology to a point where it's a good thing, and I think it certainly helps. And it's very clearly, in data published, that the use of ultrasound minimizes groin complications. So I think that definitely helps, because all of those needles passing through, even if you're not hitting arteries, you're passing through muscle in a patient who's fully anticoagulated. So you're going to get a hematoma, and that's what you don't want to see when they go home, certainly, or during the procedure.
And Dr. D'Souza, you shared earlier in one of your slides, and I think this is what generated this one, scheduling flexibility for AF ablation case at any time now. The question came in right after that, said, did you previously only schedule AF ablations first, or did you do them last, expecting them to stay overnight?
Yeah, we used to, prior to, so I sort of combined use of Vascade with same-day discharge, but prior to, we used to try to, prior to the bed crunch, we used to do the patients who would go home first. It made sense because you could watch them in the hospital for as long as you needed to, and then do the patients who were going to stay anyway. Now everybody goes home, with some exceptions, of course, that we had talked about earlier. And so we can do an AFib ablation first if we want to. We can do a device second. We can do that first. It doesn't really matter. More importantly, now if I start a case in the afternoon, I don't have to worry that we're not going to have a bed, because I can still send the patient home within. In general, we'll finish these cases by, 4. Another thing I did with hospital administration was negotiate and say, listen, I'm giving you beds, so I need you to free up space and or people, so that if there's that sort of window of 5, 6, 7 p.m., they still got to go home. And so if I do finish the case at 5, I'm going to send the patient home at 7. Figure it out. Get me staff, get me people to be able to do that. And they did. They were very supportive of it, because they realized that this was an important initiative for the hospital. And so, we had sort of like a border bed, we call it, or something like that, so that the patient could go there. We don't have to use it that often, but we have it. And then now I don't have to be concerned that the patient is not going to get discharged, even if I finish the case at 4:30 or 5 o'clock in the evening.
Okay. And I'm jumping around a little bit of the questions, but just on that note specifically, you shared earlier that there were some clinical and some social considerations for some of the patients. And I think those are the 5 to 10% that are staying home or staying overnight. Do you find, and the question was, do you find typically considerations are more social or clinical that cause them to stay?
Yeah, I found it to be honestly more social, because we can usually manage a lot of those clinical situations. I had mentioned heart failure and diuresis is usually the main one. I don't really have groin-related complications or anesthesia-related complications. It's almost always they're in heart failure and they need diuresis. But for me, and just this is general where we practice and where we see patients in satellite clinics, that distance is enough that scares them that they prefer to be in the hospital. But honestly, most people say, I'd rather sleep in my own bed than in the hospital. And so it's really a lack of ability to provide care, because you are asking your loved one who's there in the house with you to make sure everything's okay, that they feel okay. There's not really excessive amounts of nursing that has to happen, but it's ideally someone else is around. So the patients who live alone and live far away and they don't want to go to their local hospital, those are the ones we end up keeping. And so that number ends up being pretty small, to be honest. Almost everyone wants to get out.
And next question, and I'm paraphrasing on this one. If you had one piece of advice for someone's getting started to establish an early ambulation or same-day discharge program, what would that be?
Yeah, I think like anything, try not to pick the sickest people in the later cases first to send them home. If you're going to send a patient home, have it be your first case, have it be a paroxysmal, straightforward, relatively healthy person with support. Watch them for as long as you feel comfortable till you think that they're okay to go. I mean, right now we basically sit them up in 2 hours and send them home in 3. So I'm monitoring for very long periods of time after, which I'm comfortable with based on all of the metrics we had talked about before. And then sort of expand and broaden once you feel comfortable. And as I'd mentioned, having support staff, whether they be nursing to make sure the patient's okay, you yourself going back to see the patient or an APP to make sure they're okay, and then someone that follows up with them after the next day, I think is maybe overkill, but not harmful. And certainly, just another thing that gives us peace of mind that someone's keeping an eye on them after they left the hospital. They really do appreciate the phone call the next day to say, you doing okay? Any issues? That kind of stuff.
Okay. And just two more questions. One, essentially, was the move to 95% same day discharge for AF patients, was that a gradual or immediate process
It was gradual? As I mentioned, we were only sending the first cases home at first, and then we were sending the second ones too after we felt that we could do it, and then expanded the indications beyond what we had talked about. And now, as I mentioned, almost universally the standard is you're going to go home that day. And so that's been my standard for this whole year. And again, patients appreciate it when we talk to them about the procedure. They're like, "Oh, I thought I had to stay in the hospital for 2 or 3 days, and this was gonna take a long thing. But I can have this done on a Friday and be driving and back to doing stuff on Monday," that kind of thing. And so I think that's been helpful in terms of talking to patients about the procedure, and also a lot of the hospital related logistics. So yes, it wasn't like I flipped a switch and every single patient was going home. You have to be careful, of course. And so but I do think it is within the realm of standard of care. Other people throughout the country are doing it. I think this is just an added tool to be able to do it easier.
Okay. And the last question, what has been the biggest improvement in terms of patient satisfaction, Foley, groin access, Foley catheter, groin access. It's a, sorry to paraphrase, but I think that's
it's okay. Yeah, so I think that the Foley catheter I stopped using, a couple of years ago. So I can't say that my Foley catheter usage has decreased, though it certainly helps in terms of if a patient, sometimes we get fooled. You put the patient on the table, you check their airway pressure when you cross the transeptal, and you're like, it's high. I did not think this patient was going to in heart failure. I need to give them some Lasix, but I can't. They don't have a Foley, and I don't really want to put a Foley in right now. If I sit them up in 2 hours, as I mentioned earlier, I can still give them IV Lasix. It's perfectly fine. So I don't have to wait 4 or 6 hours, and that time frame allows me to diurese the patient and still get them home. So even heart failure isn't like an end all, can't go home kind of thing. For me, that was the big one before, but I think that's changed significantly. But honestly, the biggest patient satisfaction change for me is patients going home that day.
okay.
Not staying overnight. The groin stuff has been great. The Foley catheter stuff I mentioned wasn't necessarily a difference. Our complication rates were low, but that going home same day has been a huge difference in terms of how happy patients are. And I think that I would be the same way if I could go home that day instead of having to stay in the hospital. It's a big burden on patients and families, and yeah. Honestly, anyone who's had to sleep in the hospital, for all of us who are residents, it's miserable. So it's the worst night of sleep you'll ever get. And so
I don't think they're having to sleep in the hospital as frequently as they used to these days, which is amazing. So, Dr. D'Souza, there's a couple more that have come in, and you just mentioned one of them. Do you foresee any challenges post-COVID from administration? But I think really the essence of that question is, do you think anything's going to change with same-day discharge post-COVID?
Yeah, it's a good question. I think that, as I'd mentioned, COVID-19 made us look at a lot of our workflow and things that we did and say, you know what? Do we really need to see the patients in person? Do we really need to do this? Should we really be doing remote monitoring for more of our devices? Like a lot of things that actually improved care that we were forced to. Obviously, there was a lot of bad that happened with it, but I think that the answer is no. That this will still continue to be an important metric because there are lots of other things that we have to deal with in a busy hospital about getting patients in and getting patients out. And so I don't foresee that someone's going to come back and say, we're not going to let you use the device anymore, because I have proof. I have lots of data that I personally gathered with your guys' help to say, and I do recommend for someone who's trying to have a battle with administration about getting this product on the shelves, which is a battle. My joke for many of the things I got approved last year is I had to give away one of my children. And so if you gather data and you show it to them, you can't argue with that. Show how many patients went home that didn't, gather procedural times, and you guys as a company help me with that, and bring it back to them and show them the cost savings. You can analyze it and basically prove to them that this is cost effective and better for patient care. And what administrator could argue with that? So no, I think that this, as all of us know, this last year, it's been particularly difficult to get new products on the shelf.
Okay.
This was not after I proved it. In the past, you could just choose to use something because you wanted to use it, and there wasn't necessarily as much difficulty. But now you really have to prove worth for any product that you're using, which is honestly not necessarily a bad thing, so that we're not driving up the cost of healthcare. But it also requires us to be diligent about what we do for patients and how much money we're spending on each of our patients for their procedures and stuff like that.
Yeah, and it's one of the reasons why we spend so much time during the launch. Is just making sure if we're adding cost to procedure, that we're adding some value to that. This is a separate question, but just the question that came in is are you seeing a protamine shortage? Are you still using protamine for cases? And just a little bit of background: the Ambulate Continued Access Protocol. We did have one arm of that continued access. Or the CAP clinical trial that began when the Ambulate trial ended and then ran until we got FDA approval. So that continued access protocol was one of those arms was no protamine, but Just are you guys experiencing a protamine shortage? Are you hearing about that? And are you
Yeah, it's a good question, Roger. I personally, we have not, but I have heard about it. I don't reverse with protamine for patients. Obviously, we've had a reaction or a vasectomy in the past where there's concerns that there might be a cross reaction. But also, you don't have to reverse when you use this device. I mean, you can. If the ACT is above 400 and you want to have your hold times be a little bit shorter, 2 versus 5 minutes kind of thing, then you can do that. But I think unfortunately we do deal with medication shortages all the time,
Okay.
related to production, whether it be isoproterenol or something else. And so I think that if this becomes a big deal in terms of the use of protamine in certain procedures and inability to use it, this would be a clear solution to that, of course.
But probably hold a little bit longer for some patient considerations.
Yeah, if your ACT is out of range, we hold for 5 minutes instead of 2 minutes.
Okay, great. Dr. D'Souza, the only thing is, so first of all, thank you. Really appreciate the patience while we kind of work through some of the questions, which frankly, these got quite a few questions. So I appreciate the engagement of the audience on that. I did just want to point out that you will be sharing some additional part of your story from in an upcoming EP Lab Digest article that will be in the next month's publication, I believe. And Chris, you can fact check me on that, but I believe that's for next month. But so for anyone in the audience that wants to take a look a little bit further at some of the before and after and the change in workflow, that will be in the EP Lab Digest article. With that, Dr. D'Souza, I just want to say thank you. I really sincerely appreciate you taking your time away from your 2 lovely children that were nice enough not to wander into the room, and I didn't get any dogs or anything else from my side. So I appreciate you joining us tonight and sharing your story with the group that's in the audience tonight. So, and for the rest of everybody, thank you for joining. We hope that we're listening, because we've gotten a lot of feedback not to dictate, but to share what others are doing in their individual facilities and that's all we're really trying to communicate through these. So Dr. D'Souza, sincerely thank you. I appreciate the time as always.
Sure, of course. Happy to help. And if anyone has any questions or wants to reach out to me directly, happy to to chat in more detail. Always nice to learn from each other and try to do the best we can for our patients. So so I'll let you guys go. Enjoy dinner and your evening, and take care everybody and be safe. Bye-bye now.
Thanks, Chris. Chris, are we signing off then?
Thank you.
Great. Thanks everyone. Thanks for joining. Bye-bye.